Good evening, everyone. Thanks for coming for this seminar. Today, we are going to talk about electrolyte abnormalities in acutely ill, both in adult and children. We are going to talk about 10 electrolyte abnormalities: sodium abnormalities, potassium abnormalities, magnesium, calcium, phosphorus, both low and high. First, hypernatremia. Before we talk about hypernatremia and hyponatremia, let's talk about the basics. It will be only one slide, it will be short and sweet. The total osmotic activity of the solution is summed osmotic activity of all the solute particles in the solution. When two fluid compartments are separated by a membrane that is not freely permeable to solutes, the solutes will not distribute evenly. So the relative osmotic activity between two fluid compartments is expressed as tonicity. As you can see, when there is a permeable membrane, the solute travels across the membrane, so it called tonic. That means there is no difference between these two compartments. On the other hand, if the permeable membrane allows does not allow the free movement of the solutes, then one compartment that has more solute is called hypertonic, one has less solute is called hypotonic. It is very basics. Let's dive into what happens in the body. The plasma osmolality is contributed by three elements in the plasma. One, sodium, number two, glucose, and third, BUN, blood urea nitrogen. So 2 times sodium, glucose over 18, BEN over 2.8 gives plasmosmolarity. Out of these three elements, the blood urea nitrogen traverses across the membrane freely. So it does not contribute to the tonicity, even though it contributes to the osmolarity, but does not contribute to the tonicity. Tonicity is the one that determines the movement of fluid across the semi-permeable membrane. So the effective plasma osmolarity is contributed by sodium and glucose. The glucose in normal level does not contribute that much, while it contributes only 2% of the effective plasma osmolality. The effective plasma osmolality is otherwise called tonicity. If the tonicity is equivalent to the plasma sodium, that is called isotonic. If it is lower, it is called hypotonic. If it is higher, it is called hypertonic. This is how the terminology of tonicity comes about. Okay, with that basic, let's dive into hypernatremia. The hypernatremia reported in 25% of ICU patients. The approach of hypernatremia based on extracellular volume, whether the patient has hypovolemic or normovolemic or hypervolemic. Let's talk about hypovolemic hypernatremia. Hypernatremia, in this hypovolemic, they not only they have low extracellular fluid volume, and they are the fluid loss, which is causing low extracellular volume, is hypotonic to the plasma. As a result, the tonicity of the plasma goes up, resulting in hypovolemic hypernatremia. All the fluids in the body are hypotonic to the plasma, whether it is nasogastric, urine, and all of them are has a sodium less than 135. So when the loss of fluid happens, would result in hypernatremia. In other words, the sodium elevation says there is a fluid deficit in the body. All of the fluids contain sodium, so loss of these fluids associated with sodium depletion, that also one needs to be keep in mind. So what are the consequences of hypovolemic hypernatremia? The hypernatremia draws water out of cells and decreases the cell volume. This effect is most prominent in the brain. The shrunken brain cells begin to regain volume after about 9 hours. Then idiogenic osmolytes develops within the brain cells. The cells can return to their normal state after about 48 hours. At 48 hours, this equilibrium completely, that means the cells adapt to the shrinking effect of hyponatremia. So the 48 hours is a determinant whether the patient has acute hyponatremia or chronic hyponatremia. The most common complication of hyponatremia is hyponatremic encephalopathy. It presents with lethargy, cognitive impairment, delirium, seizures, and even coma. It can also Hyponatremia can cause rhabdomyolysis, and it has negative inotropic effects. But as of now, there is no evidence of heart failure as a result of hyponatremia. So how do you manage it? It's very important. Whether the patient has hyponatremia or hyponatremia, when the patient presents with hemodynamic instability, meaning hypotension, one should treat with isotonic saline irrespective of the sodium level in the body. So, first address hemodynamic instability. The second address hyponatremia. How do you address it? Infuse hypotonic fluids. Most common fluid we use is half normal saline. There are books advocate E5W in these patients. It's kind of hard because the rate of correction may be more than zero point 0.5 milliequivalent per liter per hour. As a result, they can predispose to cerebral edema, especially when the higher the serum sodium level, you got to be very slow. In my own experience, when the sodium level is real high, meaning if it goes 180 and above, anterior tube feedings are the best way to deal with hyponatremia. Place the NG tube and start doing, even if you do a free water, the gastrointestinal tract does it more effectively than intravenous fluids. Thus, it does not decrease serum sodium rapidly. As a result, there will be a slow decrease. And of course, one needs to monitor serum sodium as you are treating the patient. These patients need to be in ICU, and serum sodium level needs to be monitored every 2 to 4 hours. So, rate of correction, aggressive infusion of hypotonic fluids is discouraged because of the fear of cerebral edema. It is more so in children than in adults. I have done a lecture on cerebral edema, so not cerebral hyponatremia in children. There are three important factors predispose the patient to develop cerebral edema. One being age, number two being sex, that means reproductive age group. All women are susceptible. Third, associated with hypoxia. Most of the children, 30% of the patients with bronchiolitis do have hyponatremia, so they are predisposed to develop cerebral edema. Keep that in mind. So rate of correction should be less than 0.5 milliequivalent per liter per hour. Slower, you do better. Normovolemic hypernatremia, it results of water loss without significant sodium loss. It occurs because of replacement fluid is hypertonic to the fluid that is lost. For example, if you're replacing nasogastric drainage with normal saline, then they will end up getting into normovolemic hyponatremia. So you have to monitor those patients. And the selective loss of free water that occurs in diabetes insipidus. So diabetes insipidus, as you all know, it's a disorder of renal water conservation. It's characterized by loss of urine that is largely devoid of solutes, so free water loss caused by ADH deficiency, antidiuretic hormone. There are three types of DI. One is central DI, that is failure of ADH release from the posterior pituitary. It happens in patients with surgical resection, traumatic brain injury, subarachnoid hemorrhage, and autoimmune diseases. The second category is nephrogenic DI, most likely it is the most common because the impaired renal responsiveness to ADH, and that happens because of amphotericin, aminoglycosides, dopamine, and lithium, hypokalemia, and the recovery phase of acute tubular necrosis. But this, it is less effect on the body than, or it could less chances of causing hyponatremia than central DI. Central DI causes hyponatremia very quickly. And another category is called gestational DI, gestational diabetes insipidus. It's a result of vasopressinase enzyme produced by the placenta. It inactivates ADH, usually seen at the end of second and in third trimester. So when the patient has hyponatremia or excessive urinary loss, one should think about gestational DI, not gestational diabetes mellitus alone. So one should check the urine specific gravity and serum sodium. How do you make the diagnosis? Look at the urine osmolality, usually below 200 milliosm. I usually check the urine specific gravity, usually 1.005 or less. In nephrogenic DI, the osmolality is 200 to 500 milliosm. How do you treat? Central DI, treat with desmopressin. What is desmopressin? It is a synthetic analog available in tablet, intranasal spray, and per enteral preparation for subcutaneous or IV injection. Especially after surgical resection of pituitary tumor, if we develop DI, you have to first start with IV infusion, then switch over to subcutaneous, then tablet or intranasal spray. That by doing it so, you will not see yo-yo effect on serum sodium. So you can maintain the serum sodium. Otherwise, serum sodium level goes up and down. And another category is nephrogenic DI. It is not that as fearsome like central DI. It is treated with non-steroid anti-inflammatory drugs. It increases renal responsiveness to ADH. Among non-steroid anti-inflammatory drug, indomethacin 2 milligram per kg per day has been shown to be more effective than others. The third category is hypervolemic hypernatremia. It often happens because of sodium bicarbonate infusions and excessive infusion of isotonic saline for hypertonic fluid loss. We tend to see in patients with DKA because we tend to give 1.5 to 2 maintenance of with normal saline. There is end up having hypervolemic hyponatremia. When the patient has normal renal function, it's not a big deal because excessive sodium and water are excreted. Kidney does a pretty good job. The problem comes when there is impaired renal function. When there is impaired renal function, you need to aid with diuretics and hypotonic fluids. This is an algorithm how to treat or how to deal with hyponatremia. So hyponatremia, look at the volume status, whether low extracellular volume, normal extracellular volume, high extracellular volume. The hypotonic fluid losses you see from urinary or GI losses and impaired thirst. The impaired thirst you see in patients with extremes of age, in neonates, and also in geriatric. How do you do? When the blood pressure, when there is hemodynamic instability, treat with isotonic saline, otherwise use hypotonic fluid. When the sodium is more than 180, please use enteral feeding to correct hyponatremia slowly over 48 to 72 hours. You will be better serving the patient. Otherwise, they develop cerebral edema, seizures. It's kind of hard to revert them back at that point. When the normal extracellular fluid volume, hypotonic fluid loss is replaced with isotonic saline replacement and DI in this patient. Again, hyponatremia treated with hypotonic fluid, desmopressin for central DI, and non-steroidal anti-inflammatory drug for nephrogenic DI. In hypertonic fluid gain, and if the kidney function is normal, usually it responds on its own. But if there is impaired renal function, you have to assist with furosemide and diuresis. Next is hyponatremia. Hyponatremia is the one of the most, well, this is the most common electrolyte abnormality in my practice. I am sure it is in all hospital medicine practice across the globe. It is found in 30 to 40% of the hospitalized patients, irrespective of the etiology. So, before we talk about hyponatremia, let's talk about pseudo-hyponatremia. What is pseudo-hyponatremia? The plasma has two phases, aqueous phase and solid phase or non-aqueous phase. The small electrolytes like sodium confined to the aqueous phase, the large molecules such as lipids and proteins located in the solid phase. But 95% of the plasma is water. So there is normal little difference between the measured and actual sodium concentrations because only the 5% doesn't make a big difference in the calculations. But that becomes challenged when the protein level goes up more than 12 gram per deciliter or triglyceride level goes above 1500 milligram per deciliter. So when there is a hypertriglyceridemia of that magnitude and hyperproteinemia of that magnitude, your the measured serum sodium is skewed. Very important to remember. And what are the conditions associated with pseudohyponatremia, hyperproteinemia that could result from HIV disease, immunoglobulin infusions, monoclonal gammopathy, multiple myeloma, and Waldenstrom's macroglobulinemia, hypertriglyceridemia that can present in alcohol abuse patients, diabetic ketoacidosis, hyperlipidemias, especially type 1 and 5, pancreatitis, and type 2 diabetes, poorly controlled ones, and hypercholesterolemia, biliary obstruction, hepatitis, intrahepatic cholestasis, and primary biliary cirrhosis, and also some inborn or enzymatic defect can cause hypertriglyceridemia, hypercholesterolemia, and hypertriglyceridemia too. So how do you calculate or measure the plasma osmolality? Thus, you differentiate pseudohyponatremia. The measuring plasma osmolality will be normal in pseudohyponatremia, and corrector will be reduced less than 275. Normal being 285 to 295. It depends on the book you read, 280 to 290 or 285 to 295. The corrected sodium is equal to measured sodium plus 2.4 times glucose minus 100 over 100. I think there are other formulas to more every 100, above 160 reduce 1.6. But this book explains it is kind of much easier. So this is an example. If the serum sodium concentration measured was 130, the blood glucose level is 600, the correct serum should be 130 plus 2.4 times 5 gives 142 milliequivalents. It is of course, even though it is theory, one should recognize whether it is pseudo hyponatremia or real hyponatremia. But we are going to talk about the hyponatremia um, in particular. So one is, again, it is based on extracellular fluid volume, like in what we have seen in hyponatremia. So hyponatremia is also divided into hypovolemic hyponatremia, normovolemic hyponatremia, and hypervolemic hyponatremia. In hypovolemic hyponatremia, there will be a low extracellular fluid volume and low sodium. You see, the sodium loss results in hypovolemia. It stimulates renin-angiotensin-aldosterone system. The released angiotensin causes release of ADH from posterior pituitary. The ADH promotes water retention by the kidneys. That you see in patients with on thiazide diuretics, adrenal insufficiency, and cerebral salt wasting syndrome. The diagnosis you do by history, like usage of diuretics and adrenal insufficiency if you have a prior history, and cerebral salt wasting syndrome. Often you do not have a history, but I am not going very detailed in this particular lecture, but I have done detail in that article I wrote in e-medicine. Please look at that one. Or if you guys are interested, I can talk about cerebral salt wasting syndrome extensively. And second thing is checking urinary sodium. Less than 20 milliequivalent tells you extrarenal. If it is more than 20 milliequivalent, it is either renal or cerebral salt wasting syndrome. Second group is called normovolemic hyponatremia. This is the most common cause of hyponatremia, especially in hospitalized patients. Why that happens? Uncontrolled non-osmotic release of ADH from pituitary. What is non-osmotic stimuli? Most of the time, physiological stress, pain, and usage of medications, which we commonly used, especially in med-surg floors, medical surgical floor, like morphine, that promotes the release of ADH from the pituitary, and or excessive water intake. Most of the time, it is because of non-osmotic stimuli for the ADH release from pituitary. Etiologies are SAADH, that is the most common cause of normovolemic hyponatremia. Primary polydipsia is very rare. Physiological stress, again, falls in the bucket of SAADH. And hypothyroidism, again, very rare, even though most books want us to test for hypothyroidism when you deal with hyponatremia. SAADH, hypotonic plasma with inappropriately concentrated urine. What does that mean? When the serum sodium is low, urine osm is more than 100 with the elevated urine sodium. That clinches the diagnosis SAADH. And of course, there are 4 or 5 parameters you need to fulfill before you make the diagnosis of SAADH. Hypervolemic hyponatremia as a result of salt and water retention, with water retention exceeding sodium retention, that happens in patients with advanced heart failure, cirrhosis, and renal failure. How do you treat hyponatremia? The management of hyponatremia is determined by 2 factors. One, presence of extracellular fluid volume, whether it is hypovolemia, normovolemia, or hypervolemia, and presence or absence of hyponatremic encephalopathy. Among these two, of course, both of them are important. When there is hemodynamic instability, that takes precedence on everything. Airway, breathing, circulations. You need to fill the tank. That means you need to replace the volume loss. The other important thing is hyponatremic encephalopathy. It likely appears when the hyponatremia is acute. That means when it develops in less than 48 hours. 48 hours is the real cutoff point, because the acclimatization happens within the neurons. The maximum effect happens within 48 hours. Usually acute happens within 48 hours. And if it is anything beyond 48 hours, we call it as chronic. There is no correlation between the severity of hyponatremia and the appearance of severity of encephalopathy. So, the plasma sodium concentration has no role in the decision about initiating hypertonic saline. If the patient has hyponatremic encephalopathy, you do need to treat with hypertonic saline. The absolute number of serum sodium doesn't have any value. Some patients can have hyponatremic encephalopathy when they are in 110 or 120. Children can have hyponatremic encephalopathy even when the serum sodium is 132, 131. The so-called 125 cutoff is not true across the board. Please watch my hyponatremic presentation. What are the symptoms of hyponatremic encephalopathy? Most of them it's non-specific. Nausea, vomiting, headache, and ataxia. I want to tell you a few things. So, in a bedridden patient, ataxia cannot be elicited. Headache in geriatric dementic patients, you cannot elicit. The same true in infants and children. You cannot elicit these two. So you have to depend on nausea and vomiting that oftentimes attributed to something else. We received morphine or something, the gastrointestinal issues, so on and so forth. So you got to have a high index of suspicion, especially when the serum sodium is below normal, that is less than 135. When they have these symptoms, act upon it. You do not damage anything, but save them from further deteriorating into agitation, confusion, seizures, and coma. Although early symptoms can be non-specific, the presence of any symptom that suggests possible cerebral edema is an indication for rapid correction of hyponatremia with hypertonic saline. We'll talk about it, how rapidly one should correct hyponatremia. This is predominantly adult, but I will give the pediatric perspective. Use 3% sodium chloride. 3% sodium chloride has 513 milliequivalent per liter when compared to normal saline has 154 milliequivalent per liter. Give IV bolus 2 ml per kilo or 150 ml, that is an adult value. My practice, I give 4 ml per kilo in children. Until the symptoms resolve. This regimen can be given via peripheral veins. Very important. There's lots of pushback from pharmacy when you do that one because serum sodium is only 132. Why are you doing it? Number two, oh, it will corrode you to the peripheral veins. You need to have a central vein. Please, preventing cerebral edema is much more important than causing corrosiveness in the peripheral veins. Very important point. Access assess after serum sodium has increased by 5 milliequivalent. Even by increasing 5 milliequivalent, that should abate all CNS symptoms. That means cerebral edema should resolve by just rising 5 to 7 milliequivalent from the baseline. If there is no improvement, find out there must be another cause for the symptoms. For example, there may be associated encephalitis or meningitis. So one should look if increase in serum sodium of 5 milliequivalent did not show any improvement. Very important point. Okay, that's following limits you need to follow because one of the fallout of hypertonic saline when you're treating hyponatremia is osmotic demyelination syndrome. So you have to be cognizant of this fact. The initial increment of serum sodium should not exceed 5 milliequivalent in 2 hours or 10 milliequivalent in 5 hours. The daily increment in serum sodium should not exceed 10 milliequivalent on the first day and 8 milliequivalent on subsequent days. Again, this is an adult book. So final plasma sodium should not exceed 130 milliequivalent per liter. What he's trying to say is the overshooting can happen that can cause osmotic demyelination. So he wanted to have a buffer. When you treat with hypertonic saline, the serum sodium sometimes goes beyond, sometimes goes into 145, 150 range. So you want to avoid the iatrogenic osmotic demyelination syndrome. So correction of sodium that is too rapid or overshoot the normal sodium concentration can produce devastating neurologic disorder caused by osmotic damage to the myelin sheath of brainstem neurons. That is called osmotic demyelination syndrome. It has a biphasic course. Initial presentation, they will have a varying degrees of altermentation along with seizures. The second phase is the worst, the profound deterioration of overall health with dysarthria, oculomotor dysfunction, quadriparesis, and even locked-in syndrome. Some patients are more susceptible than others. Number one, overshooting. Number two, when there is an underlying liver disorders, they are more prone to or protein energy malnutrition associated with hypokalemia. All these can associated with higher incidence of osmotic demyelination syndrome. Initially, the osmotic demyelination syndrome very devastating consequences you cannot prevent once that happens. But that's not true anymore. You can treat early identification, treat with immunotherapy or steroid therapy can prevent the development of ODS. Just read the article published in eMedicine, please. To reduce the risk of osmotic demyelination, the maximum rate of correction for sodium is limited to 8 to 10 milliequivalent per liter over any 24-hour period. The endpoint of serum concentration is 130. It is to provide buffer against overshooting the endpoint. Overcorrection of serum sodium occurs as many as 25% of the cases. That is huge. So, if you anticipate and do accordingly, probably you can avoid this overshooting. The overcorrection is caused by, it's not because you give 3%. What happens is when you give hypertonic saline, it causes diuresis. It's hyperosmotic. It causes diuresis. As a result, serum sodium goes up. It's more frequent in patients who had thiazide diuretics associated hyponatremia. This diuresis can be prevented or terminated by desmopressin. How do you do that? The indication for desmopressin is if the increment of serum sodium exceeds the limits. If there is an abrupt increase in urine output, that means more than 100 ml per hour, again, adult value, in children 2 to 4 ml per kilo per hour during corrective therapy with hypertonic saline. As a routine measure, where overcorrection is a risk if you think, especially when they have underlying liver disorder, hyperkalemia, protein energy malnutrition. So being proactive is not a bad idea. How do you do that? 2 microgram by subcutaneous injection every 12 hours. Caveats: desmopressin is not advised in patients who had SAADH, but fluid restriction is mandatory while during treatment with desmopressin. When there is an asymptomatic hyponatremia, it is much easier. Don't get too excited when they are asymptomatic. Number one, symptomatic, you need to early identification because the symptoms are very non-specific, like nausea and emesis, ataxia, so on and so forth. But when they're asymptomatic, when there is hemodynamic instability, use with isotonic saline and treat the underlying cause. You should be fine. For example, in normal volume, it's an hypovolemia. Most of the time, it is because of volume loss, GI and urinary loss. Correct that one, you should be fine. In normal volemic hyponatremia, most of the time, SAADH, fluid restriction. The fluid restriction in acutely, it is not that hard, but in chronic SAADH, fluid restriction is not palatable, not followed by the patients. Those patients may need demiclocycline. What does it do? Demiclocycline blocks the effects of ADH. Or one can use vaptans. Vaptans, there are two kinds, conivaptan and tolvaptan. Tolvaptan is available oral, conivaptan available IV. The only issue is they are very expensive. When there is a hypervolemic hyponatremia, furosemide diuresis could theoretically correct this problem. If the kidney function is good, it is easier to do it. If the kidney function is impaired, again, you have to take an appropriate action to treat the underlying cause. The second one is potassium. The basics of potassium is when compared to the serum potassium, the body potassium is so huge. So we are dealing with small minuscule of body potassium when you are treating serum potassium. Small amounts of potassium lost in the stool, 5 to 10, and sweat. The majority of the potassium loss is in the urine. It's very important to remember that one. So when there is an acute kidney failure or any kind of renal insufficiency is associated with potassium retention that causes hyperkalemia. The renal excretion, how does it happen? The potassium reabsorbed, most of them reabsorbed in proximal tubules, the distal convoluted tubule and collecting duct. The potassium secretion occurs in response to plasma sodium. When the serum potassium goes up, the increased potassium excretion happens, and also it is all affected through aldosterone. So when there is an aldosterone deficiency or adrenal insufficiency, there is potassium secretion is affected, And of course, it causes sodium and water retention. As a result, hyperkalemia will be the manifestation of aldosterone deficiency or slash adrenal insufficiency. So how do you treat with then let's talk about hyperkalemia. The hyperkalemia is caused by two important things. One is transcellular shift. That's what you will see in most of the time in ICU or acutely ill patients. Another one is depletion through kidney and of course extra-renal losses like gastrointestinal loss. The transcellular shift happens when you use beta 2 agonists, especially when you do like 15 or 20 milligram per hour albuterol slash salbutamol outside the United States that can cause hypopotassium. So you need to watch the potassium levels, especially when you're using higher level of bronchodilators. Alkalosis of any origin could be respiratory and metabolic that can cause transcellular shift. Alkalosis push the potassium into the cells, thus hyperkalemia. Acidosis push the potassium outside the cell that causes hyperkalemia. Hypothermia, accidental or induced. Wow. Especially when you kind of keep hypothermia 32 to 34, potassium drops significantly. You need to replace it, otherwise, they will go into cardiac asystole. And insulin, especially when you're treating with diabetic ketoacidosis, you got to give higher potassium. We typically give 40 milli equivalent in the IV fluids. Sometimes we need to do potassium chaser to keep the potassium up. The potassium depletion can be the result of potassium loss in the kidney via the kidneys or via the gastrointestinal tract or because of diuretic therapy, nasogastric drainage, alkalosis, and magnesium depletion. How do you evaluate potassium hypokalemia? Spot urine potassium. When it is less than 30, that means there is an extra renal loss. So renal loss, then check the chloride. If it is less than 15, nasogastric drainage, alkalosis. If it is more than 25, diuretics or magnesium depletion. Even though I put this one, in practicality, we don't go into this one because the potassium loss is very obvious. Diarrhea, NG drainage, alkalosis, diuretics. Associated hypomagnesemia, we always check mag level so we will know. So you treat potassium and the magnesium simultaneously. So major cause of extrarenal loss is diarrhea. Normal potassium loss in stool is 5 to 10 milliequivalent daily. In secretory inflammatory diarrhea, the potassium loss can be as high as 15 to 40 milliequivalent per liter. Clinical manifestations, severe hyperkalemia causes diffuse muscle weakness. The abnormalities in ECG is present in 50% of the cases. This is the most common things we see it. What are the EKG abnormalities? Prominent U waves, flattening and inversion of T waves, and prolongation of the QT interval. The hyperkalemia can add to the risk of serious arrhythmias from other conditions such as myocardial ischemia. My own experience with the hyperkalemia severe, it can cause cardiac arrest. So keep that in mind. It is not benign. How do you replace potassium? The usual replacement of fluid is in potassium chloride is 1 to 2 milliequivalent per liter, which is translated into 20 milliequivalent per liter. We automatically place potassium in the IV fluids as long as kidney function is fine. So when there is a hypopotassemia, like hyperkalemia, we ran 20 milliequivalent 100 ml of isotonic saline infused over 1 hour. If the hypokalemia is severe, you can go up to 40 milliequivalent per hour. There is a max we go up, but this book says it can go up all the way to 100 milliequivalent per liter. But you have to be very, very careful because any kind of small error can cause asystole and death. So whenever you do the potassium replacement through IV, The patient needs to be in ICU, need to be on cardiorespiratory monitor. Be careful, and there should not be any room for error when you do an IV potassium replacement. When there is a resistant refractory to potassium replacement, always check underlying magnesium, hypomagnesemia, that needs to be repleted in order to get the potassium back up. Next one is hyperkalemia. Hyperkalemia as a result of potassium release from the cells, transcellular shift, or impaired renal excretion of potassium. There is another category is called factitious hyperkalemia that you see in patients with hemolysis, thrombocytosis, severe leukocytosis, trauma, delays in processing blood specimen. Except in delays in processing specimen trauma like hemolysis during venipuncture, thrombocytosis, severe leukocytosis, I treat them as severe hyperkalemia to avoid the cardiac effects. Transcellular shift happens in patients with acidosis. You see in DKA patients, invariably the potassium will be high in spite of body potassium depletion. Second, tumor lysis syndrome, especially when you are treating cancer with cytotoxic therapy, when the cell load is high, when the cell load is 75, 100,000, invariably they develop acute tumor lysis syndrome. The characteristic feature of acute tumor lysis syndrome, hyperkalemia, hyperphosphatemia, hypocalcemia, and hyperuricemia. It's often accompanied by acute kidney injury. Hyperkalemia is immediate threat to life, needs to be deal with it right away. When there is impaired renal excretion, again, because most of the potassium is excreted via kidney, that can cause hyperkalemia, also seen in patients with adrenal insufficiency because aldosterone effect and drugs, again, affect the potassium excretion. The transcellular shift happens in patients with beta blockers, digitalis, and succinylcholine, and reduced renal excretion when you use AC inhibitors, angiotensin receptor blockers, amiloride, non-steroidal anti-inflammatory drug, spironolactone, and trimethoprim sulfamethoxazole. The earliest change in EKG, you see tall tapering T wave that is most evident in the precordial leads V2 and V3. Then P wave amplitude decreases and PR interval lengthens. The P waves eventually disappear and the QRS complex widens to produce complete heart block. The final event is ventricular fibrillation or systole or asystole. So when you look at this picture, when the serum potassium is 4, EKG is normal. When it goes up, the tall peak T waves happens. Then prolonged PR interval happens. Then P wave disappears, resulting in complete heart block. When it exceeds or when it goes high, then developing ventricular fibrillation and asystole. So how do you treat? Number one, cardiac stabilization. How do you do cardiac stabilization? Either by using calcium gluconate or calcium chloride. Calcium gluconate 10 ml IV over 3 minutes and repeat after 5 minutes if necessary. 10% calcium chloride only for circulatory collapse. We give 20 milligram per kilo. It has a triple amount of calcium content than calcium gluconate. Second, oftentimes we use everything simultaneously, even though I say second and third. It is not on priority basis. First, calcium. Second, insulin glucose infusion. 10 units of insulin, regular insulin, plus 50 ml or 50% extras on IV bolus. Albuterol 20 milligram inhaled aerosol. And sodium cyclosilicate 10 gram every 8 hours for 48 hours. Then decrease the dose. And if it is because of renal insufficiency or a real high, and you need to do immediate hemodialysis in these patients. Third element is magnesium. The basics, average size adult contains 24 grams of magnesium. Little over half is located in bone, less than 1% located in plasma. 67% of mag in plasma is in the ionized or active form. The remaining 33% bound to plasma proteins or chelated with the divalent anions such as phosphate or sulfate. Ionized mag is very specific, but it's not measured routinely. Ionized calcium is measured routinely, but not ionized magnesium. We usually measure total magnesium. I want to show you the normal serum magnesium level 1.7 to 2.4, less than 1.7 is called hypomagnesemia, and 2.4 about 2.4 is called hypermagnesemia. So another thing I want to throw, so the plasma mag level is kept in normal level by urinary excretion of mag. So when there is a mag free diet, what happens is the urinary mag excretion is completely comes down to zero to maintain the plasma mag level. So the urine plays a significant role similar to potassium, the mag level, plasma mag level. So magnesium deficiency, meaning less than 1.7 milligram per deciliter, the predisposing conditions are drug therapy because they lose lots of mag in the urine, furosemide, aminoglycoside, proton pump inhibitors, and insulin transcellular shift. Alcohol use disorders, diabetes mellitus, diarrhea, and acute myocardial infarction 80% of the time. So checking mag level is very important in these patients. It oftentimes associated with other electrolyte abnormalities like hypokalemia, hypophosphatemia, hyponatremia, and hyperkalemia. Cardiac manifestation of mag deficiency can be coronary ischemia, arrhythmias, digitalis toxicity, and hyperactive CNS syndrome. Magnesium depletion, as I told you earlier, accompanied by other electrolyte abnormalities like sodium, potassium, phosphate, and calcium, associated with arrhythmias like torsades, neurologic manifestations, altermentation, tremors, hyperreflexia, and generalized seizures. What is hyperactive CNS syndrome? It presents with ataxia, slurred speech, excessive salivation, diffuse muscle spasm, generalized seizures, and progressive obtundation. Symptoms often triggered by loud noises or bodily contact. So, in persons with low magnesium level, with this symptom complex, one should entertain hyperactive CNS syndrome. Treatment is simple. Treat mag depletion. Vernix. It's often seen in patients with alcohol abuse disorders. MAG is required for the transformation of thiamine into thiamine pyrophosphate. So, MAG deficiency can promote thiamine deficiency even in the face of adequate thiamine intake. So, magnesium checking MAG level is very important in alcohol abuse patients. The normal daily requirements, adult males 420, female 320 milligram. Oral preparation available as mag oxide 400 milligram, which gives 241 elemental mag. IV preparation available as mag sulfate, it gives 98 milligram per gram. So how do you treat mild hypomagnesemia? Which is mild hypomagnesemia is defined 1.2 to 1.7. We replace 1 milliequivalent per kilogram for the first 24 hours and 0.5 milliequivalent per kg daily for the next 3 to 5 days. Our practice is when it is less than 1.7, and again, you see whether the patient has underlying cardiac disease and all those stuff, we immediately give IV mag to correct to normal serum sodium. We like to keep it around 2. Moderate hypomagnesemia defined as less than 1.2. 6 gram max sulfate in 250 to 500 ml isotonic saline infused over 3 hours, followed with 5 gram max sulfate, again the same 250 to 500 isotonic saline over the next 6 hours, then 5 gram max sulfate every 12 hours for the next 5 days. So there is a probably body depletion of mag in these patients. When there is a life-threatening hypermagnesemia, the way we do it much more aggressively, infuse 2 gram mag sulfate over 2 to 5 minutes, followed with 5 gram mag sulfate over next 6 hours and 5 gram mag sulfate every 12 hours for next 5 days. When you are dealing with renal insufficiency, you need to use gingerly and follow the mag level because magnesium is secreted via kidney. So you have to check the levels quickly, and you should not overshoot into hypermagnesemic levels. Otherwise, follow the protocol I have given. On pediatric doses for mag is 50 milligram per kilo. It is given from 25 to 75 milligram per kilo. I typically use 50 milligram per kilo, sir. So how to monitor mag replacement? To be honest, we don't follow this one strictly, but this is recommended. Add So collect the urine for 24 hours. If the urine mag excretion is less than 12, that means there is continued mag depletion. The urine magnesium excretion is more than 19, that means the sufficient magnesium stores. The typical practice, what I do in ICU is when the mag level is less than 1.7, I give 50 per kilo in children. In adults, you need to use the max of 2 grams. 50 per kilo and check the mag level. If it's lower, I repeat the doses. And because most of the patient cannot tolerate PO, once a patient is tolerating PO, you can do mag. I have done continuous infusion of mag only in those patients for different reasons, not for the magnesium depletion. For example, in patients with status asthmaticus who's not responding, those patients sometimes we use continuous mag infusions. That is completely different category, but typically for hypermagnesemia, I do repeated doses to get back to the normal level. Hypermagnesemia. Hypermagnesemia is uncommon. It presents in 5% of ICU patients. It happens in patients with massive hemolysis. The other conditions associated with hypermagnesemia are adrenal insufficiency, hyperparathyroidism, and lithium intoxication. Clinical features of hypermagnesemia when the mag level is more than 4 milliequivalents, normal being 1.7 to 2.4, if it is more than 4 milliequivalent, hyporeflexia will become evident. More than 5 associated with first degree AV block, that means prolonged care interval. More than 10 complete heart block, more than 13 cardiac arrest. In addition to cardiac effect, my experience is they will have a respiratory muscle weakness. You got to intubate right away. So mag sulfate, the way you do is based on the acuity of the situation. When you have torsades, you need to push real fast. Eclampsia, you need to push it fast. Otherwise, just magnesium depletion alone, just run it over 30 minutes an hour. That's how I do it. Most of the serious complications, hypermagnesemia, as a result of calcium antagonism in the AV conduction system in the heart. When there is a severe hypermagnesemia, in addition to do IV calcium gluconate and volume infusion with furosemide, prepare for hemodialysis because you are doing temporizing measures while you are getting rid of, especially when the level is like 15, 16. Get the hemodialysis done aggressively. That is the best way to remove MAG. Calcium. Calcium is the most abundant electrolyte in the human body. 99% is in the bone. The PTH and vitamin D promote calcium resorption from bone and maintains plasma calcium levels. Calcitonin inhibits calcium release from the bone. The plasma calcium is available in three forms: ionized, bound to albumin 80%, and complexed with sulfate and phosphate anions 20%. As you can see, the active form is very small fraction. The rest of them are bound to either albumin and other anions. Hypoparathyroidism is a leading cause of hypercalcemia in outpatients, especially in adults. But in ICU, it is the most common because we tend to have alkalosis, magnesium deficiency, renal failure, sepsis, massive transfusion, pancreatitis, rhabdomyolysis, tumor lysis syndrome. Often all are associated with hypocalcemia. Most cases of venous calcemia in the ICU have no adverse consequences. You check, you will see hypercalcemia treated. But if it becomes severe, it can cause hyperreflexia, paresthesias, and seizures, and tetany. We all have been taught Chef-Stockstein-Troussier sign. Chef-Stockstein reported in 50% patients with normal calcemia. So eliciting or going by Chef-Stockstein is not a good way. Always measure serum calcium. Troussier sign, again, considered a reliable sign, but poorly documented. Cardiovascularly, hypercalcemia can cause hypotension, decreased cardiac output, and ventricular ectopic activity. How do you treat 10% calcium chloride or calcium gluconate? Calcium chloride has 3 times elemental calcium than calcium gluconate. It's available in 10 ml ampules. Give bolus of 200 milligram of elemental calcium in 100 ml isotonic saline over 10 minutes. Follow with continuous infusion of 1 to 2 milligram per kg per hour for 6 to 12 hours. Monitored ionized calcium levels hourly for the first few hours. For pediatricians, calcium gluconate dose is 100 to 200 milligram per kilo. Calcium chloride, 2. If it is non-life-threatening, 2.5 to 5 milligram per kilo. In life-threatening situation, 20 milligram per kilo. Next is hypercalcemia. Hypercalcemia is usually the result of hyperparathyroidism or malignancy. The malignancy is associated with hypercalcemia or multiple myeloma, breast, lung, and ovarian cancer, squamous cell carcinoma of the head and neck, and lymphomas. It manifests as nausea, vomiting, constipation, and ileus. Cardiovascularly, it can cause hypovolemia, hypotension, and shortened QT interval. Renal, it can cause polyuria and acute kidney injury. Neurologically, it can cause confusion, depressed consciousness, and cough. The manifestation usually appear when the calcium level goes more than 12.5. It happens always when the serum calcium level is 14. I typically, when it is exceed more than 10 or 11, I start giving saline boluses, furosemide decreases it because we do not want to have these clinical manifestations. So how do you treat? Saline infusion, furosemide, calcitonin, glucocorticoids, biphosphonates, and dialysis. You need to be very prompt because cardiac effects can be lethal. Isotonic saline, maintain the urine output 100 to 150 ml per hour in children, 2 to 4 ml per kg per hour. Reduce the serum calcium by 1 to 2 milligram per deciliter. Calcitonin, 4 units per kilogram subcutaneous every 12 hours, 24 to 48 hours. Biphosphonates needs to be started. When you have hypercalcemia, especially when you think it is because of hyperparathyroidism or because of cancers, you have to do simultaneously all of them. Soldronate or pamidronate. First-line drugs, both of them are, and soldronate may be more effective than pamidronate. The dose is 4 milligram IV over 15 minutes, and pamidronate is 60 to 90 milligram IV over 4 hours. Glucocorticoids, IV hydrocortisone 200 to 400 milligram daily for 3 days, then prednisone 10 to 20 milligram daily for 7 days. Common most effective in patients with myeloma and lymphoma, glucocorticoids. Phosphorus. I think we are coming close. I'm going to rush a little bit faster. Hypophosphatemia. It is inorganic phosphate is predominantly in intracellular location. Hypophosphatemia present in 80% of patients, especially common after major surgery, multi-system trauma, and fulminant sepsis. It happens because of reduced absorption from GI tract, increased phosphate excretion in the urine, or transcellular movement of phosphate into cells. It's seen in patients with glucose loading, especially when you start TPN, you tend to see hypophosphatemia, respiratory alkalosis, physiological stress, sepsis, phosphate binding agents, all associated with hypophosphatemia. It affects oxidative metabolism. As a result, it can cause low cardiac output or does not help cardiac output. It can cause anemia, impaired hemoglobin dissociation, and impaired AT production. The muscle disorder, it can cause rhabdo and respiratory muscle weakness. Yeah, that's true. Hypophosphatemia usually asymptomatic. I'm going to talk about that. So how do you treat serum phosphate or potassium phosphate? There is one another thing available. It's not in the book called neutrophosphate. So when the patient is tolerating, we use neutrophosphate, or when they already have a associated sodium and potassium issues, we use neutrophosphate. And sodium phosphate, in addition to replacing phosphate, it gives sodium level 4 and potassium 4.3. So when do you treat? Usually, if it is more than 2, we do not treat. Someone commented 80% of the ACD, yeah, 80% of them do not have. But when it kind of falls less than 2, I do treat. How do you treat? 20 millimole, if it is 40 to 60 kilos, and 61 to 80 kilos, 30, and 81 to 120, 40 millimole. If it is less than 1, you need to be very aggressive in replacing. In children, we do 0.15 to 0.3 millimole per kilogram over 4 to 6 hours. That's how we treat. Can you please remove the scratches because it may be hindering others? Hyperphosphatemia. Most of the time, hyperphosphatemia is associated with renal disease, tumor lysis syndrome, and hypoparathyroidism. It's often associated with insoluble calcium phosphate complexes with the deposition into soft tissues. Hyperphosphatemia, often associated with hypocalcemia. How do you treat? Phosphate binders. To reduce GI absorption of phosphate, the drug uses sevelamer. The dose is determined by the serum phosphate level. If it is level is 5.6 to 7.4, 800, 7.5 to 8.9, 1200 to 16 milligram 3 times, more than 9, 16 milligram TAD. Sevelamer gluconate is preferred over sevelamer hydrochloride. It's often associated with hypercalcemia, so in addition to the phosphate binders, we will do the calcium. The initial dose is 1334 milligram 3 times daily. Most of the hyperphosphatemia in children associated with underlying renal disease, please consult with a nephrologist at this point of time, often need hemodialysis to revert back and followed by them. This concludes the talk on electrolyte abnormalities in acutely. Thank you for watching. If you like it, please share it with others.